My name is Anna Padoa. I'm a urogynecologist. I work in Israel, about 20 kilometers from Tel Aviv. What can I say about myself? I have a disclosure that I had the honor and pleasure of editing this book on the overactive pelvic floor, which the other speakers and my co-chairs are actually, all of them wrote a chapter in this book. So we are basing much of this workshop on the book itself. In this talk, I will talk about the role of the pelvic floor in sexual function. We will then move on to the overactive pelvic floor and sexual dysfunction in women. I'm a gynecologist, so I will talk about female patients. I will say a few words about female genito-pelvic pain penetration disorders, and I will relate to emotional issues and pelvic floor overactivity and how the two are related. So already back in 48, as all the physios and also the MDs know here, Kegel described a technique, the Kegel exercises, for strengthening the striated pelvic floor muscles as a treatment, successful treatment, which is now evidence-based for urinary stress incontinence. During this first description of the technique, several women also reported enhanced erotic sensations in their genitals and a greater ability to experience orgasm. And also many decades later, pubococcygeal muscle strength was found in another study by Graeber to be higher in orgasmic than non-orgasmic women. The question is, what is the cause and what is the effect, and what is the relation of these two issues? In 1966, Masters and Johnson published their book on the human sexual response, and their book was based on direct observation of sexual intercourse and sexual activity, heterosexual activity, and they described the occurrence of voluntary and involuntary pelvic floor contractions during sexual arousal in both genders. They described involuntary rhythmic contractions of the pelvic floor seen regularly during orgasm, and they also observed that such contractions tended to decrease with age. Again, many years later, there was a study by Bolen and colleagues who observed in a small group of, I think, 11 patients, 3 different patterns of orgasmic contractions. So it seems like in this group of young patients, and it was done during observation, direct observation during masturbation. The first time of contractions included a small number of regular contractions subjectively indicating orgasm. The second type of patients described both subjectively and was also objectively observed twice as many regular contractions followed by additional irregular contractions. But there was also a third type of patients, a small number of women who reported subjectively experiencing orgasm without any pelvic floor contraction. So it seems that it is not necessary for the experience of orgasm to see a levator ani contraction activity. Once again, theories developed regarding what is the occurrence of orgasm and the connection with the pelvic floor. And in 1974, Scherfi described the orgasm as just a vascular event. So she described venous congestion and stretching of the pelvic muscles to stimulate muscle nerve endings so that the muscles begin to contract. And this is perceived as the subjective experience of orgasm. And Shafik in 2008 described such pelvic floor activity as a clitorimotor reflex resulting from clitoral stimulation. The same group of Shafiq actually observed what happens to the levator ani during sexual intercourse, and he described the levator ani to be involved in vaginal elongation, uterine elevation, and vaginal muscle contractions, as possibly with the aim of facilitating the male genital response or as a response from penile thrusting. Now, the question is whether pelvic muscle training, as we see there is no clear direct connection between pelvic floor contraction and orgasm. We can see orgasm without pelvic floor contraction according to some studies. So the question is whether pelvic floor muscle training can enhance sexual arousal and orgasm, or if maybe it's unrelated. So Mess and Gear in '85, they carried out a study in a group of women in which there were three groups of patients. A group of patients who engaged in pelvic floor contractions without additional sexual stimulation, another group of patients who carried out pelvic floor contraction with sexual fantasy, and another group of patients engaged in sexual fantasy alone. And what they found is that even vaginal contractions alone, without sexual fantasizing, such patients reported subjective sexual arousal relative to baseline. So the possible mechanisms are maybe that there is an increased stimulation of stress receptors and pressure receptors, which during contraction, that can lead to arousal and increased orgasmic potential, but possibly pubococcygeus exercises can focus a woman's attention on her genitals. So this focusing of the attention to the genitals might result in an increased perception of pleasure, which is subjective and not caused by the contractions in a mechanical way. Now, there are also some, so this study might show that there is an advantage to pelvic floor muscle training in increasing or improving orgasmic potential in women. But there were quite a few studies in small groups that showed that pelvic floor muscle training did not increase orgasmic potential, despite increasing pubococcygeal strength in patients. So it seems that, contrary to the promising findings of early studies, in actually a relaxed pelvic floor and not a contracted pelvic floor are related to better sexual function, and that possibly much of the effect of pelvic floor muscle training is due to the attention on the pelvic area and genital attention to genital organs, so that it improves sexual function. Now, if we move to sexual function in women with pelvic floor dysfunction, studies on pelvic floor dysfunction have conflicting results. The main problem with such studies is that they take a very heterogeneous group of women usually, including low tone and high tone pelvic floor. So there were, when we talk about urinary incontinence, we may see lower urinary tract symptoms like stress incontinence resulting from pelvic floor, from low tone pelvic floor. And we can see overactive bladder symptoms who can be more related to high-tone pelvic floor dysfunction. So sometimes these groups of women are put in the same basket while doing studies, so it's difficult to get to conclusions. But lately, just in 2015, so very recently, there was one group in a physiotherapy practice who took actually their patients and divided them into low tone and high tone pelvic floor dysfunction patients. Now, there was those 85 patients. The large majority of them had high tone pelvic floor dysfunction, vestibulodynia, and vaginitis and vaginismus. And what they found, this group, when they tried to subdivide their pelvic floor dysfunction patient, is that the patients in the middle age group, so most probably those with the low tone pelvic floor dysfunction, had better sexual function than younger patients, less than 30 years of age, and older postmenopausal patients. Another finding was that women with low tone pelvic floor in general had higher sexual function according to sexual questionnaires than women with overactive pelvic floor. And women with a low tone pelvic floor had lower FSFI scores than the high tone pelvic floor. So now that we've seen that there is probably, it is quite clear that sexual function is disturbed when we take a specific group of patients with overactive pelvic floor. I will say a few words about female genito-pelvic pain and penetration disorders. So there are many causes for genital pain, but when the pain lasts more than 3 months and it becomes chronic, and there is no clear cause like inflammation, infection, we talk about vulvar pain syndromes, of which about 16% of female population has been found to suffer. The ISVVD issued a classification of vulvar pain and related to specific disorder in group A and vulvodynia group B, which can be generalized or localized. And mostly we will talk now about vestibulodynia, which was previously known as vulvar vestibulitis syndrome. Now, provoked vestibulodynia, which is the sharp burning pain at the entrance of the vagina in response to vestibular touch or attempted vaginal entry, is very often accompanied by vaginismus, which is a recurrent or persistent involuntary spasm of the outer third of the vagina musculature interfering with intercourse and characterized by high tone pelvic floor, which is what we're talking about. Now, the DSM-5 put these two syndromes together and called them female genito-pelvic pain penetration disorder, as often, very, very often, they overlap. And sometimes the vestibulodynia can be the causing factor, and the vaginismus can be a reaction to that. And in other situations, the high tone pelvic floor is the one causing skin irritation because of friction. So we will now tend to relate to these two conditions as one condition. If we focus on the external symptoms, on the provoked vestibulodynia, the typical symptoms are of introital dyspareunia, or maybe sometimes even with when it's primary, even with the tampon use before any attempt to sexual intercourse. Sometimes there is partial or complete cessation of intercourse because it is too painful, and often pain is described also with activities like bicycle riding, and not only with the attempts of insertion of a tampon or coital intercourse. Tenderness may be confined to the posterior or to the anterior vestibule, and it can be primary or secondary. Now, on physical examination, it is important to inspect the appearance of the vulva. Very often, the only finding is a mild redness of the vulvar skin. We perform a Q-tip examination, exerting mild pressure on the vestibule of the vulva, which is the area between the hymenal ring and an imaginary line, which is called the line of heart. Usually there is a hypersensitivity either in the whole vestibular area up to the periurethral area or only in the posterior vestibule. It is also essential to assess pelvic floor muscle tone, as we saw that actually we're talking about a pathology involving both muscle spasm and external tenderness. So possible causes, it's probably a basket of diseases, and it's not, most probably, we're not talking about one single pathology, but different possible pathologies. Maybe there's a recurrent chronic inflammation following repeated vulvovaginal infections. Some patients may have some neurogenic vulnerability and a tendency to exaggerate in inflammatory response due to genetic variations, and there are also some studies showing specific polymorphisms going with a tendency for vulvodynia. And I find Andrew Goldstein's classification very helpful for clinical practice. Andrew Goldstein divides provoked vestibulodynia in 3 groups. Hormonally mediated provoked vestibulodynia, which is what happens when we give very low dose oral contraceptives during menopause or during breastfeeding. This results, the vulvodynia in this case results due to a lack of estrogen and androgen activity on the vulvar skin, and usually the whole vestibule is involved. The second group is the one we mainly maybe deal with, which is the hypertonic pelvic floor muscle dysfunction. Usually it goes together with other symptoms of overactive pelvic floor, with other musculoskeletal disorders, with anxiety, and it involves mainly the posterior vestibule. And the third type is a type which he described as neuroproliferative. There are some studies which found a very dense area with a lot of nerve endings in the vulvar skin of samples of vestibulectomy, patients who had this operation to take out the skin of the vestibules, which is not very popular today, but it was popular years ago. So possibly this tendency to neuroproliferative activity in the vulvar area may be congenital or acquired, and the tenderness is in those cases, is of the entire vestibule. Okay, so what happens with the overactive pelvic floor and sexual arousal in women with sexual pain disorder, in this group of women? It seems like genital response in women with dyspareunia is not impaired, is normal. Now, what was found to be impaired by studies is fear of pain. There were many studies done using clips of with different contents. Brouwer carried out one of those studies, and they found that there was diminished genital arousal in patients with dyspareunia, but also in patients with no dyspareunia during erotic film viewing, when the participant was under the threat of a painful stimulus to the ankle. This stimulus was actually never delivered, but they knew that they were expecting something painful to happen to them, not in the genital area, and this was enough to cause a diminished genital arousal. So this is already a hint that the fear of pain is what is the main problem here, and not the pain itself, maybe. So fear of pain may result in increased pelvic floor activity as a part of defensive reaction. And we know that pelvic floor muscles, like other muscle groups, and especially, for example, neck and shoulder muscles, are innervated by the limbic system and highly reactive to emotional stimuli and states. In another study of the group of Ellen Lan in Holland, actually they showed that as proving what I was saying about the limbic system and its impact on the pelvic floor, that patients observing an anxiety-provoking film had increased tone of the pelvic floor measured by EMG. Now, we were talking about the issue of arousal, and there is some empirical evidence that shows that increased pelvic muscle activity by itself, so an overactive pelvic floor by itself, may be associated with reduced blood flow to the vagina during sexual stimulation. So the contraction itself creates a vicious cycle, which is causing, in the end, lack of lubrication, and therefore we have this increased friction resulting in pain and more contraction with tissue damage and irritation of the skin. So there is a connection between contraction, decreased lubrication, friction, and increased contraction. We have a vicious cycle which can connect clearly vestibular pain, which is external pain and skin irritation, with an overactive pelvic floor and the limbic system. Now, when again, those studies, several studies were done using videos with different contents. So pelvic floor activity was found to be significantly enhanced in all participants in study, both women who are with normal sexual function, and also women with, who have a history of sexual abuse. When they were shown a sexually threatening film excerpt, they had increased pelvic floor activity, but in sexual abuse survivors, this reaction occurred also with the videos showing consensual sexual content. So it is important to remember that PTSD, post-traumatic stress disorder following sexual abuse, is very common in the female population. It's about 20%. The topic of sexual abuse can be present in 20% of the female population. And the hormonal and neural circuit activation that normally leads to positive experiences and sexual arousal is already overactive in a negative sense in post-traumatic stress disorder. And it is directly connected to anxiety, fear, and other PTSD symptoms, so that sexual contents mean threat rather than pleasure, and so we have as a result muscle contraction and an overactive pelvic floor, which is very common in PTSD patients following sexual abuse. Okay, so I just want to remind that there are some other emotional issues related to an overactive pelvic floor, and not only PTSD following sexual abuse. There's a lot to say about attachment style. Insecure attachment to the partner can lead to dyspareunia as a result from pelvic floor overactivity. Overactive pelvic floor patients often have also other stress-related complaints like other muscle pain or tension headaches and tension and sexual arousal headaches. Sometimes painful orgasm is a result of the contracted pelvic floor. And there are many behavioral issues that have to do with sometimes a limited non-coital sexual repertoire and a narrative of sexual behavior which is very classical with no alternatives. And sometimes there's a vicious cycle starting from this, leading to an overactive pelvic floor due to repeated attempts of having full intercourse while it is causing pain. So these are the main references, the two chapters which are the main reference for this talk.